here with Jonathan Rubenstein. We're talking about a subject that's of interest to me, and I'm going to tell you why. First of all, I'll let you in on a secret. I'm extremely well preserved. I am from the last generation of people who were trained in incisional keratotomy, pre-excimer laser, to refractively change corneas, and also from the first generation of people who was trained in fellowship with the excimer laser. And I started doing excimer, and I was always doing cataract surgery, and incisional keratotomy fell by the wayside. More recently, once I started doing femto, I revisited. I know this is boring to you, but humor me. I mean, when I started doing femto second, it was so easy to add LRI onto the procedure for low astigmatism patients that I thought, for those patients I'm not doing femto on, why shouldn't I offer this to them too? What I want to know is this. In this high-tech, AI, computer-controlled world, is there still a role to perform manual LRI? Let me start out there. I'm curious what you're going to say.
Well, yeah, and that's a good question. That's a question that's asked over and over again. And just a little history from me, I've been involved in teaching these courses on manual LRIs, both at the Academy and at ASCRS skills transfer courses for probably 20 years is when I started doing that. I mean, it's been a long, long time. And every year I expect this course isn't going to be renewed. You know, this technique is going to go away. There's really no need for this. It's being supplanted by the techniques of femtosecond laser incisions, great advances in toric IOLs. But in reality, I think for a cataract surgeon or any refractive surgeon, you need to know all the different modalities for tackling astigmatism. We all know that uncorrected astigmatism postoperatively is a bad thing to have. It leads to decreased best corrected visual acuity. It leads to poor visual acuity. So correcting astigmatism is very important. So I think in your toolbox, you need to know how to do everything. And I think there is still a place for peripheral corneal relaxing incisions. And specifically, there's a number of instances where I think it's important.
Yeah, so, give me clinical context where it might be beneficial.
Number one is price. Of the various ways of correcting astigmatism associated with cataract surgery, this is the least expensive to the patient. And cost control is important. We have to think about those kind of things. So it basically costs the patient just whatever price the surgeon wants to charge. I'd say community standard, that may be a $500 fee, something like that. It's still going to be a lot cheaper than paying for a toric IOL, which is the IOL and the surgeon charge, or paying for femtosecond laser treatment during cataract surgery. And there are many of these patients that have astigmatism that can't pay for that, and I just do it anyway. So if they can pay, I charge them. If they can't, I don't. So cost and ease of application is probably the easiest. So really technologically, all you need are two things. You really just need to have an astigmatic marker and some sort of diamond knife. So there's not a lot of material and technology involved in it. So it's very simple. Second thing is there are patients that have very low degrees of astigmatism and may not be able to afford a femtosecond laser and may be just below what you can correct with a toric IOL, especially if it's with the rule astigmatism. So they may have one diopter with the rule. We know now with posterior corneal astigmatism, if you put in a toric IOL in those patients, you may overcorrect them, basically. So how do you correct the patient that has between 0.8 and 1 diopter with the rule? Well, relaxing incision, peripheral corneal relaxing incision, manual with a diamond blade is a very effective procedure. So that gives you a chance to correct astigmatism on these patients and still try to get the best refractive result postoperatively you can possibly achieve. Likewise, if you've got a patient that has a high degree of astigmatism, more than a toric IOL can correct, our typical toric-only IOLs can correct a very large degree of astigmatism, up to 5 diopters. But some of our newer multifocal, trifocal IOLs have a little bit more limited toric range. So if you want to correct a higher degree of astigmatism, if your IOL only goes up to 3 or so, you can then add peripheral corneal incisions in a patient where you don't have the access to a laser, for example. So very low levels, very high levels. Patients that can't afford anything else, those are all possibilities. And then the last group of patients, what I find this is helpful on, are some patients have a little bit of non-orthogonal or a non-orthogonal axis on their topography. You don't really know exactly where the true axis is. So instead of the arms of the astigmatic Myers being exactly at 180, maybe one's at like 20 and the other's at 180, for example. What do you do in that patient? Where do you put your toric eye? Well, it's hard to know, but you can center a peripheral corneal relaxed incisions over the apex, basically, of these arms of the non-orthogonal bow tie on corneal topography. So I think that's another way you can use these incisions to sort of customize them to a cornea that's not so abnormal you wouldn't do anything, but just a little bit abnormal but stable, where you can place these incisions on the non-orthogonal axis of the bow tie.
Now, particularly for the U.S. market, where we don't have access to T2s, we don't have access to ZCT 100.
Right.
In other words, where we don't have access to low cylinder toric lenses, there's a need that is either ignored or has to be met, and this is, I think, this is really the only way to meet it. Let me ask the opposite question. Is there, given the fact that we're already making multiple full thickness incisions in these eyes, these are not astigmatic keratotomy patients who are not having cataract surgery, this is in the context of cataract surgery. Aside from ectatic eyes, is there any reason not to do this?
No, but I think that would be the two main contraindications. Maybe if somebody had ocular surface disease, that you'd worry about actually healing of the incisions, or you'd worry about the accuracy of your measurements, or maybe you weren't sure. And this is true for any astigmatic correction. So the only thing specific to these incisions, I would think, would be if there was some sort of peripheral cornea abnormality. And that's very, very important in any astigmatic treatment, is if you assess preoperatively, when you do your preoperative last assessment of a patient, you're going to say this patient may need astigmatism correction. It may need it at a 10-degree axis. Let's look at the peripheral cornea at 10 degrees and 180 degrees away and make sure that area that I'm planning to do perhaps incisions, whether it's a laser or manual incisions, let's make sure that cornea is normal. So it's very important to make sure there isn't old scarring, there isn't Dellin formation, there isn't something there. But I think that would be just abnormal corneal tissue in the area, as you alluded to, Josh, would probably be the only reason to avoid it.
Let me ask you one last question, and it's a sort of a barrier-lowering question.
Mm-hmm.
I would not mind putting out the money for a gemstone blade, but I already know that my medical center is not going to be able to clean it. If I am interested as a cataract surgeon in doing LRI, even understanding that it may not be as potent as with a diamond blade, can I just get a disposable 600 micron steel blade and mark and cut, and knowing, first of all, I've done exactly what I'm talking about. I've never had a perforation, but if there were a perforation, I can handle. I already have multiple perforations because I've made wounds. Is there any reason not to get into the LRI sphere by just getting some disposable 600 micron blades?
No, I don't think so. I mean, I think a diamond blade is more optimal. I think it's easier to cut.
I don't think anyone would argue with
but
that.
I think that a cheaper alternative like a metal blade is a possibility. Another cheaper alternative is there are different types of diamonds. There are black diamonds that aren't quite as expensive. So you can get diamond blades as cheap as $400, that aren't terrible. And I have the same kind of situations. One of the places I operate is a university-based hosptal.
Right.
And I don't trust them at all.
Right,
to take
it's not
care
the
of
blade,
it.
it's the cleaning.
There's no question. So I think to have, to spend a couple $1,000s on a blade that you know is going to get dinged after one or two uses doesn't make sense. So there are cheaper alternatives. Steel blades is one of them, but there are also cheaper diamonds. And certainly, people interested in this is the place to look. We're at the Academy where we've got the largest display floor of vendors that you can possibly get to look at various options for astigmatic blades. And so, they're very cheaper options.
The ASCRS annual meeting is also
the
place
ASCRS
to look
is also an excellent place.
Jonathan, this is really, really, really great stuff. I mean, this is one of those difficult topics for me because we're both squarely on the same side of it, and
Right.
this is an emphasis in our residency program too. Every resident leaves the program as a competent LRI, PCRI surgeon too, which I'm proud to say.
There's one other thing I
yes,
wanted to ask,
please.
just as far as,
No, go on.
because the whole treatment, and the whole, just I think an important thing to get across in astigmatism treatment is really assessing the degree of astigmatism. It's all garbage in, garbage out. So for any of these techniques you use, you have to adequately assess astigmatism. So when you finally figure out, and the first thing I do when I do my IOL measurements is I look for astigmatism. I don't even care about the spherical power of the lens. I look, does this patient have astigmatism? What's the axis? Is it worth treating? And in general, my go-to is, even though I'm an advocate of peripheral corneal incisions, is still toric lenses. But when I do a toric IOL calculator, I'll look at anticipated residual astigmatism.
Yeah, of course.
And if that anticipated residual astigmatism is close to a half a diopter, for example, or if I'm sort of between steps in the lenses, that's when I look into adding a peripheral technique. The patient can afford a femtosecond laser, I'll use the femtosecond laser. If they can't, then I'll use a manual peripheral corneal incision. So that's another place to think about it. Even in a toric IOL patient, look at that residual anticipated cylinder, and maybe you can just add a little bit more to make them closer to plano.
Yeah, and I'm glad that you brought up, and I know this is off topic and we don't have to talk about it, but assessing OSD before doing the biometry, particularly for if we're considering treating cylinder, is absolutely mandatory.
Right.
I want to thank you for bringing this cool topic to us, and you gave a wonderful talk. You're a busy guy. I want to thank you so much for the generosity of your time. It's really quite a gift.
Thank you very much, Josh. It's always my pleasure.